Good evening and welcome you all. My name is Varun Arnagiri and I'm uh, one of the surgical registrar in Shaw Hospital in UK. And this session is going to be regarding the CBD stones, the management and the bile duct injury. Uh, to everyone, those who are participating here and those who are viewing in Facebook Live, for everyone. This is recorded and this will be uh, um, published in YouTube as well. And even the discussion part will be published in YouTube. And at the outset, I would like to thank everyone, those who have joined the Zoom interaction and also those who are in the Facebook live. And also, I thank everyone for joining this session. This is a series of session. This is the third session which I'm taking online, and this session will be targeted for people those who are appearing for MRCS, the FRCS exit exams, the Part One, Part B exams, and also most of the things which are dealt here are the UK guidelines and the UK practice protocols, and most of the protocols which I discuss here is followed by many of the hospitals in UK. Uh, Welcome, guys, and I would like to start uh, with this session and a bit of anatomy and physiology for the people those who are fresh to the uh, things. Uh, Coming on to the first slide. So just a bit of anatomy about the biliary tree. When we deal about the common bile duct stone, definitely we have to know about the common bile duct and the uh, biliary tree anatomy. In general, liver secretes the bile, and the bile is drained by the right and left hepatic duct, which forms the common hepatic duct, and the gallbladder with the cystic duct combines to form the common bile duct, and the pancreatic duct joins the common bile duct to open into the ample of water. And the pancreatic duct has got major duct and the minor duct, which is called as um, duct of Wirsung and duct of Santorini. Most of the time, the duct of Wirsung joins with the common bile duct and form drains the bile into the second part of the duodenum, which is the transition point between the foregut and the midgut. So this is a bit of anatomy for the um, MRCS graduates part one. And coming on to this slide, and this is a wonderful slide. So before we go into the bile duct anatomy and the pathology and the stones, we have to know about the hilar plate, or the liver hepatic hilum, or the hilar plate, which is in the hilum of the liver. So the hilar plate is a flat surface which is covered by the peritoneum, which consists of the structures which is there in the hilum of the liver, and which is extended laterally on the right side to form the cystic plate where the gallbladder sits, and on the lateral side, on the left hand side, it's the umbilical plate where the falciform ligament goes and attaches to the left side of the liver, left portal vein. And why should we know about the hilar plate when we have to think, when we have to uh, read about the common bile duct? The hilar plate um, helps in the detection of how far medial dissection we are doing it, and are we in danger of injuring the bile duct during our laparoscopic cholecystectomy. So in the first picture you can see the right side, the cystic plate, which where the gallbladder sits, and the gallbladder, it's otherwise called as liver bed, and the hilar plate, which contains all the structures of the liver hilum, example like portal vein, the hepatic artery, and the common bile duct. And this is otherwise called as this is called a cystic, sorry, this is hilar plate. And laterally, on the left hand side, we can see the umbilical plate, where the um, um, falciform ligament goes and attaches a ligament of teres with ligament of teres. And coming on to the next slide. So what are the common anomalies of common bile duct? The common in general, the anomalies of the biliary tree happens either in the hepatic duct or the common hepatic duct or the gallbladder, the cystic duct, and the confluence of the cystic duct and the common hepatic duct, the common bile duct as such. And there is a variation in the attachment of the pancreatic duct with the common bile duct, where it opens into the second part of the duodenum. Okay, the next thing is the let me go ahead with a few anomalies of the gallbladder and the uh, common bile duct before we enter into the main topic. So the few anomalies where there is gallbladder, especially the gallbladder, the anomalies of the gallbladder are like absence of gallbladder. There are plenty of times where we try to search for gallbladder. Many times that chances of gallbladder can be absent. There's something called as vestigial gallbladder, where the cystic duct gets narrowed and there's an atresia of the cystic duct, where from the gallbladder just stays there as a remnant organ without doing any function. And, or sometimes the gallbladder can be just a blind-ended sac or without doing any function. There's no storage capacity for the gallbladder. And other anomalies of gallbladder are like there can be a septum in the gallbladder which can divide the gallbladder into two or three multiple septae or the single septae, but the cystic duct will be same, will be one. There will be two septate gallbladder which drains the bile into the cystic duct and into the common bile duct, and there can be bilobed gallbladder, but one cystic duct with a common cystic duct which joins with the common hepatic duct to form the common bile duct. Sometimes there can be two gallbladders with one cystic duct with one common cystic duct. Can be two gallbladders with two common cystic duct which combines to form a common cystic duct which drains into the common bile duct. And there can be two gallbladder with two cystic duct, but the confluence will be so limited that the confluence straight away joins into the common bile duct. These are a few anomalies of the gallbladder and the cystic duct. Again, the anomalies of the cystic duct, like two cystic ducts combine straight away drains into the common bile duct, and there can be one gallbladder with one cystic duct which drains into the hepatic duct and which drains into the common bile duct. The other gallbladder will be straight away. It's like a normal gallbladder with normal cystic duct. There can be two gallbladders on two sides of the liver, on one on the right side and one on the left side, and one gallbladder can be having a cystic duct which drains into the right hepatic duct, but it could be intrahepatic. So in these situations, we may be we may be we not will not be uh, going inside the in the liver to clamp the cystic duct, and there can be two cystic ducts for one gallbladder which drains into the. So these are the anomalies of gallbladder. And coming on to the, and this is the intrahepatic gallbladder, where you can see the gallbladder in the, this is an MRI picture which shows the liver with intrahepatic gallbladder, where the gallbladder exists sits inside the liver. In this situation, we have to be much more cautious in dissection of the liver bed, where there's a chances of bleeding or injury to the major vessels. And there can be something called as freely mobile gallbladder with long mesentery. So in these situations, the gallbladder will be freely floppily moving around the base of the liver. And coming on to this duct of flushka, this the duct of flushka, which is very important in knowing about the biliary tree, because this the duct of flushka is nothing but a subvestigial duct which drains into the right hepatic duct. And this duct of flushka is there's a chance of injuring the duct of flushka when we dissect the gallbladder out of the liver bed, and this is called as the duct of flushka. And we'll see about the significance of the duct of flushka in the future slides. And coming on to the common bile duct proper. So, what are the anomalies of the common bile duct proper? So the first three anomalies A, B, C. So the type A, B, C. The first one is the stricture of the common bile duct proximal to the confluence of the cystic duct and the common hepatic duct, whereby the whole system gets dilated. And the second picture shows there is a atresia of the gallbladder, but there is a dilatation of the right and hepatic duct with atresia of the common bile duct below the level of the common hepatic duct, and there's a complete atresia of the right and left hepatic duct with common hepatic duct and the cystic duct. So whereby in first three types A, B, and C, there can be intrahepatic dilatation of the common bile duct, where the surgery is possible and we can do a anastomosis like hepatic anastomy in first three uh, in the first three. I think someone is uh, doing some uh, sharing the pictures and drawing the lines. Can someone not to do this? Okay. And the second the second row shows D, E, F, and G. These types are uh, there's atresia of all these types. You can see all these types has got atresia, and there is an atresia which extends into the intrahepatic region. So this intrahepatic region, when there is atresia of intrahepatic biliary tree, the surgery is not possible, and these patients will be helpful with liver transplantation. Coming on to the next slide, and this is the most common thing which most of the surgeons will be knowing, and this is choledochal cyst, and the classification of the choledochal cyst it was given by Tudani's classification. And there are 5 types of choledocal cyst. When we say about the anomalies of the common bile duct, this comes into the mind for everyone. And the type 1 is the most commonest one, which is called as a fusiform type, where the common bile duct gets dilated as a fusiform, and and uh, causes obstructive jaundice. And there is a second type where there is a circular dilatation of the common bile duct at one particular point. And the third type is otherwise called as choledococele, and choledococele, where the part of the common bile duct which gets attached to the or which gets strained to the duodenum gets dilated. It's otherwise called as choledococele, where the dilatation happens at the junction between the common bile duct and the second part of the duodenum. The type 4, there are 2 types, A and B, whether it's intrahepatic and extrahepatic dilatation, or just extrahepatic dilatation of the common bile duct. And the type 4 is intrahepatic dilatation, which is called as Caroli's disease. And when coming on to the etiology of the choledochal cyst, there are plenty of theories which is said for the there are plenty of theories which has been postulated uh, to explain why the choledochal cyst happens, and the names of the theories are called as like Babbitt's theory, and there is something called as pancreaticobiliary malfunction and early canalization. Coming on to the next slide, let me explain this bit in detail. So there are 3 explanations which are offered for this biliary. So this is for biliary atresia. Sorry, this I think I just um, went. There's a shuffling of the slides. So Babbitt's theory. In Babbitt's theory, they say that there's a pancreaticobiliary malfunction, and during the intrauterine period, which causes the dilatation of the common bile duct, or in other words, there is early canalization with dyslipidemia. For example, during the fifth week of intrauterine period, there's a early dilatation of the common bile duct during the fifth week, and with a distal obstruction of the common bile duct, which leads onto the dilatation of the common bile duct, which causes the choledochal cyst. And I would like to go skip this slide, which is the reason for the atresia. If someone wants to have a pause and look at this, they can do it later on in the YouTube. And what the most common presentation of the choledochal cyst is neonatal or the pediatric causes of the obstructive jaundice or the infantile jaundice. The baby is present with obstructive present with pictures suggestive of obstructive jaundice, and there could be swelling which appears and disappears in the right upper quadrant, like the swellings which are appearing and disappearing in like intussusception and hydronephrosis. And there are a few other causes where the swelling appears and disappears. And why this choledochal cyst is more important is there's a 30% chances of cholangiocarcinoma in these patients when it is left out or when it is not treated in a proper way. And what are the treatment of the five types of common bile duct choledochal cyst? For the type 1, we go for a hepaticojejunostomy with okay, in common in all these five types, the gallbladder has to come out, or we go for a cholecystectomy invariably. Otherwise, in type 1, we go for hepatic oxygeноstomy with the cyst excision. And in type 2, again, there can be sometimes, if it is feasible, we can try to remove just the choledochal cyst, the sacula, and primarily stitch the common bile duct, or in if it is not possible, try to go for a hepatic oxygenostomy again. In type 3, we can do a saccular sphincterotomy in the ampullae and try to keep this sac uh, open into the duodenum. If not possible, again try to do a perfect excision and hepatic oxygenostomy. In type 4 and type 5, most of the dilatation happens all over the biliary tree, and so there is a chance of there is a these patients will be helpful with liver transplantation as early as possible. There's something called as Lilly surgery. What happens is in type 4, if there is a saccular dilatation which impinges on the portal way, what they do is they leave the part of the common bile duct wall over the portal vein and just remove the mucosa so that the wall of the common bile duct get, stays there over the portal vein and forms, it just gets degenerated. It's a type called as Lilly surgery. Coming on to the relationship of the back to the anatomy again, and the relationship of the common bile duct to the other structures. So everyone knows that the common bile duct is of 10 to 12 centimeter in long. The normal diameter of common bile duct is 8 mm in a normal healthy person with gallbladder. Sometimes after the removal of gallbladder or the after cholecystectomy, the patient may have a dilated common bile duct up to 10 mm, and still that is normal. And in relation to the duodenum, the common bile duct is divided into three parts: supraduodenal, retroduodenal, and retroduodenal. The next one is the paraduodenal. Supraduodenal is nothing but is above the first part of the duodenum, and it occupies the free border of the lesser omentum, and the retroduodenal part is just behind the first part of the duodenum. The paraduodenal is just behind the uh, uh, head of the pancreas, where the common bile duct gets its attachment from the common bile ducts, merges with the main pancreatic duct to form the ample of water to drain into the second part of the duodenum. So these are the first part of the duodenum and first part of the common bile duct and the second part of the common bile duct and third part of the common bile duct. And coming on to the next slide, and this shows the uh, uh, perfect relationship between the hepatic artery, the portal vein, and the common bile duct. So the common bile duct is on the right to the hepatic artery, or the right hepatic artery, and it is anterior to the portal vein. So you can see the different levels of the common bile duct and the common hepatic duct and its relationship to the other two structures, especially the hepatic artery and the portal vein. And these are the relationship in the first part. It's are in the proximal part. The hepatic duct, the common hepatic duct is in relation between the right hepatic artery and the cystic artery, and the left hepatic artery. Always the portal vein is the posteriormost structure or the deeper structure, so it is highly unlikely to injure a portal vein during a laparoscopic cholecystectomy or a CBD exploration, and there's high chance of injury to the hepatic artery. Right hepatic artery is the most commonest structure which can get injured, and less likely to get injured is the posterior hepatic artery or the left hepatic artery. And when we come to the distal end, again the same thing. There's a less likely chances of getting the gastroduodenal artery into the field, but it's very highly unlikely to get a gastroduodenal during a laparoscopic cholecystectomy or the common bile duct. So coming on to the next slide. So when we study about the anatomy of the common bile duct, it's very important to know about the foramen of Winslow, or the foramen which connects the greater sac with the lesser sac, or the greater sac with the lesser sac. And the lesser sac, the foramen epiblanche has got its anterior surface as the lesser border, or the free border of the lesser momentum, which has got three structures in it. As I said you earlier, bile duct again towards the right, and the hepatic artery towards the left, and the portal vein towards the posteriorly. And in all means always the IVC and the aorta forms the posterior aspect of the common bile duct. Okay, so this will be helpful. This picture will be helpful people, those who are doing endoscopy or those who are interested in endoscopy. So when we enter the duodenum, there is a gross difference between the mucosa of the of the stomach and the duodenum. So thereby we can definitely identify what exactly the mucosa look like. So once the person who does the endoscopy will definitely know what's the difference between the gastric mucosa and the duodenal mucosa. So how to identify uh, the second part of the duodenum? So this A represents the uh, ample of beta in the second part of the duodenum. So once we see this bulge, either medially or laterally, depending upon the scope, and we are into the second part of the duodenum, and the ampulla can be differentiated from a polyp or something like anything, with the opening in the middle, and there will be a T-shaped mucosal fold around the ample of water. So that's how we differentiate a major papilla and the minor papilla, or the common bile duct, in the endoscopy or in the ERCP. So this T shape gives a landmark. T-shaped mucosal fold gives a landmark for the uh, landmark for the ample of water during an endoscopy or an ERCP. So this slide shows the blood supply of the common bile duct. The most important thing for in terms of blood supply to the common bile duct is the position of the major blood vessel in the 3 o'clock position and the 9 o'clock position. In this picture, we can see the common bile duct's blood supply at the 3 o'clock position and the 9 o'clock position. So when we do a common bile duct exploration, make sure that extensive dissection of the common bile duct all around the common bile duct. There's a chance of injury to the major blood vessels, and there's a chance of decreased there's an increased chance of anastomotic leak in the common bile duct. So the common, as I said you earlier, the branches of the the common bile duct is supplied by the two arteries, one from the gastroduodenal artery, or from the pancreatic superior posterior branch of the pancreatic superior duodenal artery, and from the right hepatic artery, or sometimes from the cystic artery. So here in this picture we can see there's a branch which descends from the right hepatic artery towards the distal end, and there is a branch which comes from here, and it goes above. So there are two blood supply to the common bile duct, and the venous drainage is along these veins. And especially when we come to the nodes, and as I said you, as the common bile duct is supplied by the hepatic artery and the gastroduodenal artery, so there's a chance of lymph nodes drainage into the liver hilum, and also there's a chance of lymph node drainage into the celiac nodes. So always the nodal drainage is towards the arterial supply, or the major arteries which supplies it. So this is an anatomy about the sphincter of Oddi. So as I said you, the common bile duct combines with the main pancreatic duct to form the ampulla of Wetter, which drains into the second part of the duodenums. There are three sphincters which controls the common controls the sphincter of Oddi, and this is the sphincter Choledocus, or the sphincter which is around the common bile duct, the sphincter pancreaticus, which is around the sphincter of the around the pancreatic main pancreatic duct, and this is sphincter which is around the common ampulla of Wetter, or the sphincter of Oddi. So all these three things controls the drainage of the bile into the second part of the duodenum. So coming on to the few physiology, which before we get into the common bile duct stones, and everyone knows the bile is formed from the remnants of the old blood cells which breaks into the heme and the globulin. The heme forms the bilirubin, which gets conjugated in the liver, and this conjugated bilirubin enters the bile, and it gets secreted in the second part of the duodenum and enters the intestine, and in the terminal ileum gets reabsorbed, and again so it gets into the systemic circulation and enters into the liver. So this is called as the uh, extra this actually this is the cycle of the bilirubin absorption, the intrahepatic circulation. Okay, sorry, and so in this, the most important thing which I would like to stress here is um, the formation of the stercobilirubin and the urobilinogen, where the physiology stays there. So the urobilinogen is absorbed into the blood, and which gets uh, uh, and it get the stercobilirubin, sorry, the stercobilirubin is the one which is converted from urobilinogen to stercobilirubin, which gets blocked, or when there is a block in the common bile duct, the stercobilirubin doesn't enter into the large intestine, and this gives the pale color to the stool when there is a obstructed common bile duct. There's an obstructed common bile, and I think this picture shows the physiology of the cholecystokinin, which is secreted by the distal part of the stomach and the duodenum, and the proximal uh, small intestine, which forms the cholecystokinin, which contracts the gallbladder and the sphincter of Oddi relaxation. And this CCK is the stimulus for the CCK is the presence of fat in the stomach and the duodenum, and this causes the bile to eject into the duodenum to form the micelle or the fat digestion. Okay, so the amount of bile which is secreted is 1,000 mils, and the composition of the Bile is water with plenty of bile salts, cholic acid and deoxycholic acid, and the rest of the things, the bilirubin. Bilirubin is a 3%, bile pigments, fatty acids, lecithin, cholesterol, and electrolytes. These are the proportion of the uh, bile, which is proportion of the bile, and the majority of the bile is occupied by the bile salts, the cholic, which are cholic and cholic acid and deoxycholic acid. So how, few something about the bile test. So how to easily detect bile salt in the urine? So just sprinkle some sulfur over the urine. Due to the surface tension, it gets deposited. This is called as haze test. And when there's a dip a dip a filter paper in a solution with 10% barium chloride with urine, and drop few drops of add some few drops of purchase reagents which has got ferric chloride, 10% of ferric chloride, which forms which has got 10% of, sorry, some, I think I have to, sorry, just a minute. Okay, so the green, when we drop the purchase reagent over the um, filter paper, the bilirubin gets converted into biliverdin, and that forms the, that gives a green color, which is, that gives a green color, and which shows that the bile, there's a bile pigment. So coming on to the gallstones in proper, these are the different types of stones which we can see in, even in the common bile duct, or it can be in the uh, gallbladder. So there are different types of most common types are the cholesterol stones, the faceted stones, and the mixed stones, and the pigment stones. When it comes to pigment stones, there are two types of pigment stones. One is the black pigment stone, and the second one is the brown pigment stone. The black pigment stones are due to the increased bilirubin level, which is caused by the hemolytic anemias like like hereditary hemophagocytosis, sickle cell anemia, and beta thalassemia. That sometimes it can be because of ineffective erythropoiesis like pernicious anemia and liver cirrhosis. There are chances of bile pigment stones or the black pigment stones due to the extended ileal resection, especially the distal ileum, and the total colectomy, which can cause the black pigmented stones. Coming on to the next thing is the brown pigment stone. The brown pigmented stones are mostly due to the parasitic infestation and the E. coli infection. Uh, um, it can cause a pigment stone either in the common bile duct, or sometimes it can be because it can be in the intrahepatic region, causing intrahepatic stone formation, especially when there's a chance of stone formation in liver fluke or clonakis sinensis. And what are the reasons of the stone formation is like, everyone knows that it's a 5F mnemonics. The most common, it's more common in females and fertile females, those of fatty and in 40s, and those of fair or Caucasians, or those who are in the Western world is more common. And what is the typical biliary pain? It's around the epigastric region, and we can say the dermatome is usually T7 to T9 dermatome, slightly above the epigastric, slightly above the umbilical region, T7 to T9, and usually the biliary pain is 30 minutes or more than 30 minutes. It radiates towards the back. The patient usually describes like a band of pain around the epigastric region, and the severity, they used to say the this biliary pain is much more worse than a pain when a woman delivers the baby. And the periodicity is usually intermittent, and it's less strongly associated with nocturnal onset and post fatty meal. Usually, we used to say, does it usually triggers with a fatty meal, but there's a less evidence saying that it triggers with the fatty meal. Into the next slide is the formation of, so in terms of formation of stone, how the stone gets formed. So the stone gets formed because of the three these are three trigger things which happens for the stone formation. And the mucin acts as a nidus, and it creates a crystallization around it and forms the stone. Sometimes any one part of one component of the bile, like increased cholesterol or increased bile salts or increased bile pigments, whatever, and when there's a decreased proteins, whenever there is a change in the proportion of the bile content, this leads